Next speaker is Dr. Sri Ganesh, the evergreen hero in cataract and refractive surgery, and he's going to tell us about enhancements with SMILE. On to you.
Thank you, Chitra, and for inviting me to this very nice refractive symposium. So we'll go on to enhancements after SMILE. Are my slides visible? Yeah.
Yes, yes.
So SMILE itself, the long-term stability is excellent, and what we have been seeing is that I've been doing SMILE since 2012 and about 8,000 cases, and our enhancement rate is just about 0.2%. We have treated less than 40 of these eyes with enhancements. So it's extremely rare, but let us look at the enhancement techniques after SMILE for residual refractive error. And generally there are four approaches. One is surface ablation, the other is a thin flap LASIK, and then you have the circle software, which converts the cap into a flap, and then you can do LASIK ablation. And the last is subcap lenticule extraction, or what is also called re-SMILE, where you can again do a SMILE. So coming to PRK after SMILE, this is the simplest procedure to do, ideal for low enhancements if you have just 0.5, 0.75 diopters. But epithelial thickness to be taken into consideration, especially if you're doing trans PRK, and you'll have to use larger zones. Otherwise, you may not get the adequate correction. And I generally like to use mitomycin C 0.02% for almost a minute. Again, this is controversial because some people say that about 20 seconds, it does not really matter, but the incidence of haze can be higher post-SMILE and post-LASIK if you do a ablation. And you can see this is a picture showing a faint haze, which you can see, and this actually reduces the quality of vision. And we find that there is increased risk of haze with PRK after SMILE. But the advantage of this procedure is you can maintain the flapless procedure and the biomechanics. This is a paper published in GRS which showed enhancement of using surface ablation after SMILE by Walter Secondo and group. And their incidence was almost 2.2% in 2,000 odd eyes, where they did surface ablation and found that it was quite good and effective. Then you have LASIK after SMILE, and it can be done especially if you use thicker SMILE caps of 135 microns or more, but most of us use 120 microns. So if you want to do a thin flap LASIK after SMILE, then 135 microns being used routinely, which Dan Reinstein does, and this is good for low enhancements also. Epithelial thickness, again, to be taken into consideration when you're planning the flap thickness, and femtoflaps of 100 to 120 microns are ideal. There is a risk of entering the previous interface if you use a thicker flap, and the hinge has to be planned to be away from the SMILE access incision. If you have used your access incision at 12 o'clock, use a nasal hinge. And this is a publication by Dan Reinstein group. He normally uses 135 microns cap, and his incidence of retreatment is almost 4.4%. And outcomes after thin flap LASIK, he reports to be very good. But I think if you're not using a thicker flap, then this is not an ideal approach. This again is an approach which even the company has a special circle software, which is an enhancement solution for SMILE. It allows the surgeon to convert a SMILE cap into a flap. And the circle option permits planning and creation of different incisions. And usually there are three incisions. One is the lamellar ring, and then you have the side cut with the hinge, and then you have the junction cut. And right now it's not approved in the US, but it is available in India. And there are different patterns for circle treatment. And normally we use the C or the D pattern. And this is the approach which we like now, because with PRK, again, there's a delayed recovery and there is pain, but with the circle software, of course, the biomechanical advantage of a flapless procedure is lost, but the patient satisfaction is quite good and the results are quite predictable in what we see. So most of the enhancements we do is, this is the circle software where you have the lamellar cut, the junctional cut, and then the side cut, and then you can, it converts the SMILE cap into a flap, and you can lift this flap. You can see that is how you lift a femtoflap, and you're able to easily get into the interface. And then you can go ahead, shift the patient under the excimer laser, lift the flap, and then you can do an excimer laser ablation. So it's quite easy to convert the cap into a flap with the Circle software. There is a little bit of resistance there. You can also use a two-hand technique. And then that is the
5 minutes
bed, which is done. Okay, I'm almost. This is an article showing by Ektet Chansui, demonstrating the, and he says the safety and efficacy of Circle software is very good. And Jodh Mehta and group compared the 4 different patterns and found that the D pattern was quite good in rabbit size. They also compared surface ablation, Circle software, and you can read the paper. But the last technique is smile on smile, can be done if previous cap thickness is known and can be used for higher refractive error enhancements. Epithelial thickness has to be taken into consideration. This has the advantage of maintaining a flapless procedure. After refractive cut and side cut, the suction is put off. So this is something that the surgeon does. It's not a software in the machine. So you have to put off the suction after the refractive cut and side cut. And the original axis incision is open. The old interface basically is the superficial plane, and this can be easily opened up. Then the deeper plane is dissected carefully, and the lenticule is extracted. And the minimum thickness of lenticule should be maintained for easy extraction. So I keep it at 25 or 30 microns. Residual stromal thickness should be adequate for this procedure. So basically, higher refractive errors, 1 diopter or more, you can use this. And centration is critical. Let me just show you. We have done only a couple of cases, and this is the topo pre and then post enhancement. You can see the flattening after enhancement and the reduced corneal thickness. And this is just a short video showing the procedure. So you, after the refractive cut and the side cut, you put off the suction. So you just lift your foot off, put off the suction. Then you open up the original incision, and then you get into the superficial plane, which is very easy to dissect. It's the original plane, which is above the refractive cut which you have created. Then you enter the deeper plane, which is the refractive cut which you have performed. That's the superficial plane. And the deeper, and then you can just remove the lenticule. So this is how you do a re-smile, and this was first reported by David Donate, and this is his paper in the JRS. And there is also this paper by Jodh Mehta where he has compared the various techniques and the tissue response in rabbits for those who are of you all are interested. So thank you very much for your attention.
Thank you, Dr. Sri Ganesh. That was a very informative presentation. Dr. Praveen, you could introduce Dr. Ram, and I'll just ask one question to, because I think we are really running short of time. Does it make sense to have a thicker cap if we want to do a smile on cap like as a routine, or even if you're going to do a flap on a cap? So
what happens is, if your corneal thickness is adequate, then you can have this approach. And this is what Dan Reinstein does. He has a thicker cap because he says that the anterior stromal fibers contribute more to the biomechanics. So he likes to have a thicker cap, and he uses a 135 cap, and then he uses 100 microns to do a thin flap LASIK for enhancements. But in our situation in India, generally the corneal thickness is not that good. And most of us use a 120 with micron cap thickness, and some of us even a 110 or 100 micron if we don't have adequate thickness and we are correcting a high refractive error. So in this situation, it becomes very difficult. You should not do a thin flap LASIK, because if you use a 120 micron and you have maybe like 100, you've got 100 or 110 micron, and then you have epithelial thickening also, and then you can have problems. You can enter into the interface when you're making a thin flap LASIK. So ideally, it should be 135 microns or more if you're there to use this approach.
Yes, thank you.